Like 79-year-old man with a history of previous right-sided CA 18 years ago. He's been followed with routine duplex. He's a former smoker and has never had stroke or TIA. Physical exam is unremarkable with well-healed carotid incision and normal neuro exam. Carotid duplex ultrasound shows peak systolic velocity of 400 and end diastolic velocity of 150 of the right carotid artery.
Okay, so he has a carotid about 10 years ago. And now he came just for follow-up, and he has, you know, just he had high velocity. It's a question of most of what going to do next, right? Yeah. So what do you do next?
I will complete my
right?
Yeah. Yes.
Yeah. Go ahead. Just go very quick. Yeah.
I complete my cardiovascular history, neurological history, and physical examination.
All right. And be sure.
Yeah. And I would like to ask for CTA, head and neck.
Okay. First, you have to be sure there's no symptoms, right? Because he may have a TI, he didn't tell you. So it's most important to tell him if he has any symptoms. Just change your. They didn't mention anything in the question, but doesn't mean he didn't have a symptom. So you have to ask specifically, do you have any TIA? Not TIA, it's any weakness, slur of speech, you know? Because people, they don't read books, they don't come tell you if you don't ask them. You know, he may have a slurred speech and he thinks it's something wrong or something like that. It's very important to ask him a question about his symptoms. Okay. So you do a CAT scan. What are you looking at? Why did you decide CAT scan? What are you looking for?
I would like to confirm if there is stenosis in the CT scan and compare it with the duplex ultrasound.
Okay.
And I would like to look also for the aortic arch anatomy.
Okay.
And also for the brain, if there is any sign of old infarction.
Okay. All right, that's very good. If the CT shows different from ultrasound, which one are you going to take? Like the ultrasound 400 and CT scan showed 50%.
I will reassure the patient and continue best medical therapy for the patient with repeating the duplex ultrasound.
So you test the CT scan better than the ultrasound?
I need two studies that confirm the same finding to be sure that he's really have stenosis.
Right, and you did two studies, but the problems they are not they're contradicting. And this is in real life. I'm not making it difficult for you. It's a real life. You see in the clinic that you're like 400, 500 velocity and get a CAT scan like 50%. So the question, which one I'm going to take?
The other problem ultrasound is, yes?
Mm-hmm. Yeah, go ahead.
The other problem ultrasound is sonographer dependent.
Correct.
I need another sonographer also to do the study and compare it to the CT finding.
So you think is ultrasound is more accurate than CT scan?
It is not more accurate. It will give you the velocity, it will give you the numbers, but it needs a competent operator to do it.
Okay.
But after all, I need two different studies to confirm.
All right. But let's say if you do repeat the ultrasound and still show you that is discrepancy, which one are you going to trust? I'll answer for you. I mean, it's no right and wrong in this here. It depends. You have to review the picture by yourself. Look at the CAT scan. Is it a real 50%? Is it any calcification? Because some calcification can give you a lot of shadowing. You cannot tell. So if it's measurement, some people, they measure differently, like, European is different from American, how they degree the stenosis. Because American, they degree stenosis according to the normal internal carotid artery, whereas the European, they measure it according to the bulb, the bulb. So it's big different. So I'll look at the CAT scan, see which one is more quality. And then I look at the ultrasound, see which one more quality. Maybe the ultrasound, the angle was wrong, the waveform is not right. Maybe it was very far from the stenosis. So really, I have to look for it and then decide. But you cannot say like blindly, this one's better than the other one. Everyone has plus positive and plus negative, false positive, false negative result. So in this case, if I have a discrepancy, I will review them and see which one is more like, I have a problem with it, then I repeat it. If the CAT scan calcification, I cannot see 100%, then maybe I'll repeat the ultrasound. If the ultrasound looks beautiful, waveform is nice, I will trust the ultrasound better. If the waveform of the ultrasound is bad, it's not very good, it's very far from stenosis, a CAT scan looks very good, I'll go with a CAT scan. But as we said, they should be really comparable. So if it's not comparable, you have a problem with one of them. And then you have to review the film by yourself and decide, and then you go from there. Okay?
Okay.
Okay, so you do that, and you look for the arch, you look for the type of the arch, and you look for the classification, because you want to decide to do, because most of you going to do like static, right? Okay, so what anatomical criteria you look for it, we talk about it. Patient has a steep type 3 aortic arch, but meet the criteria for TCAR. What preventive instruction will you give him?
I need him on dual antiplatelet for at least 1 week.
Okay.
And
well, let's okay. This is imagine patient came to the OR, for carotid stenting, either TCAR or transfemoral. You put him on the table, and you just before the start, your fellow tell you, oops, he didn't take any aspirin or Plavix before, he forgot to give it to him. Can you just bolus him and continue, or what you do? Which could happen,
No. I will postpone for at least 1 week.
So you cancel the surgery.
Yes.
Yes, that's correct. Yeah, don't do it. Especially because constant is very, very sensitive. So if it's not an aspirin Plavix, at least for 1 week, you stop it. If he's already anesthetics, usually not anesthetic because stent you do on the local, so patient will be awake. So if it's anything except the carotid stent, usually we overload him. Like if he come for low extremity intervention and for some reason he did not take aspirin or Plavix, you can overload him. But carotid is different. You have to cancel it if it's not an aspirin or Plavix. All right, so let's see. Patient is on dose medication, is ready for operation. Describe your procedure, the TCAR. I don't think somebody will ask about this question because we don't do TCAR, in the Middle East. So he might ask about transfemoral. So let's talk about transfemoral because more practical if you're going to ask a question in the exam, well, let me ask first, are you guys, anybody doing TCAR in Egypt?
No, boss. Nobody.
No, boss. Okay.
No, sir.
By the way, anybody can do a TCAR. Most time I did a TCAR. It's not a TCAR. It looks like a TCAR, but it's not. I mean, it's you don't have to have complicated TCAR to do it. One time I was opening to do a redo, in radiation neck. It was very late. It's before the, I don't know why we decided to take him to open it. When you open, everything is frozen. You cannot even see the common internal. So I make small incision down, open the common carotid artery, put a needle. And you can do the same with transfemoral to the common carotid. You don't have to have a TCAR. You can put a filter and you finish it. So it'll become like a TCAR. TCAR is reverse flow. But if you don't want to buy this expensive instrument, you can still do TCAR in your whatever you have. So you do exactly transfemoral, but you do it through transcarotid. You just make small incisions, common carotid, put your wire, advance your wire to the external, then you put your filter, then you stent it like it's a transfemoral. So it can be done like that. But we don't call that TCAR, but transcarotid. But anyway, so let's talk about transfemoral. So how you do transfemoral stent? Because they may ask you, become very, very common now. Let's go step by step.
Common femoral access under ultrasound guidance.
Okay.
With the 6 French sheath, then advancing my wire and vertebral catheter into the aortic arch, and cannulating the carotid artery.
This is the left. Yeah, the left. Okay, and then
in the left common carotid artery. Then I will heparinize the patient with 100 international unit per kg heparin.
Okay.
Then I will run an angiogram in 2 view for the carotid and for the brain. And then I will cannulate the external carotid artery, put my catheter there and exchange it.
Which wire?
The soft tromo, I will put it in the external carotid and advance the vertebral catheter. Then I will exchange it with the stiff wire.
Correct. Then
Then I will advance a long destination sheet into the common carotid artery, distal common carotid artery.
Correct.
Then I will advance my filter into the distal internal carotid artery.
Which filter you take? Which one you use?
Well, there is Capture-X and there is
No, but did you do stenting? Did you do any stenting? Because looks, you know the steps. So did you do it or just saw it?
I assist in 2 cases.
Yeah, 2 cases. Yeah. Which one you want? Anyone, but pick up one you want. You know, Aspirex, or you can do exact. You know, it's a HemoShield filter. You know what's the difference between HemoShield and spider filter?
No.
I mean, something extra. It's this for your life. You know, the spider filter. I mean, HemoShield. This is from Abbott. Okay. This is not attached to the wire. Okay. So you have to use their own wire, because if you don't, because the wire has a small thickness at the tip, so the filter will not go out, you know. So what happened, you put the wire first, their wire, and then you put the filter. So the filter is not attached to the wire. Why is that important? Because after you finish, you can remove the filter and keep the wire. And this is important if you have any dissection or any problems, you know. You tell me, but I'll do an angiogram before remove it. Yes, but I'll tell you what some scenario. Sometimes you do an angiogram after you finish, got to stent, and you see no flow to the internal carotid artery. So what does that mean? If you finish your stenting and you do an angiogram, you don't see no flow. What do you do?
You retrieve the filter.
What is the cause, you think? What is that?
Thrombus captured in the filter.
Or
maybe dissection.
Correct. So it's two options. Or you have dissection there, or have a filter full out of clot or debris, correct?
Yes.
So you have to remove the filter and then shoot an angiogram, and then you can tell, right? So
Yes.
if you use an HemoShield filter, the good that the filter is not attached to the wire. Okay, so if it's not attached to the wire, then you can remove the filter and keep the wire, and then you do angiogram. If the angiogram shows the dissection, your wire already there, the trulament, so it'll be easy to go and re-stent it, put a stent again or extend your stent. But if you use a spider filter attached to the wire, then when you remove the filter, you have to remove the wire. So after you remove the wire, if you do an angiogram, you find dissection, you are in big trouble. You see?
Yes.
So this is a disadvantage, okay? I mean, of the spider filter, okay? But what's the advantage of spider filter over the HemoShield? That it is the filter, when filter attached to the wire, that means the moment you fix the wire, the filter will be fixed. When you have an HemoShield, the filter not attached to the wire. So let's say for some reason your assistant, he pulled the wire down, so the filter will go down, correct?
Yes.
But you cannot push it back, because you cannot push it back. So then you are in trouble, because the filter went down and you cannot push it up. So this is only disadvantage of using HemoShield filter, because as I said, the wire has a small thick area at the tip. So when you push it down, it pushes the wire down, but there's nothing to push it up. So this is a disadvantage of HemoShield. So you have to be careful that when you use it, be sure that the wire stay in place, nobody pull it down, because this will move the filter. Okay? So this is advantage and disadvantage. The reason why you have two types of filters. So for you to decide, I can't say one is better than the other, but at least you know what disadvantage and advantage of each one, and then you decide which one it works best for you. All right. So you put a filter, and then after that?
After that, I will do another angiogram and road mapping. Then I will ask my anesthesia to raise blood pressure and to prepare atropine standby.
All right. I don't think we ask for blood pressure to be up in the stenting, because we don't clamp, you know. But yes, to prepare atropine is yes, but we don't clamp. So usually it does. I mean, it has to be reasonable pressure, but we not like a surgery. You want like a high pressure. Because it doesn't matter. You're just going to stent like in seconds. So it doesn't make a big difference in the stenting. But it's good to ask for atropine. Why need atropine?
Because the balloon will affect the baroreceptor at the
Correct.
carotid body,
And can cause?
bradycardia.
Okay. Or asystolic. Isocalcific case the patient go asystolic. So this
Yes.
is, you can see it. Yes. All right. So, but do you balloon after or before? Or you don't, you go stent right away?
No, what we did is ballooning first, then we put a stent.
Okay. In carotid, we don't do that because if you balloon first, you're going to embolize to the brain, increase your embolizations. So we do usually primary stenting. The only time we do balloon before, if the tight very stenosis, like 99%, you cannot get the stent through it, then we balloon, and we balloon very gentle. It's like 2 or 3 millimeter balloon just to open a tunnel to can get the stent through it. So if the stent can go through it, I would prefer not to balloon. Just go deployed, then balloon after that, because this way you can trap the debris in the behind the stent. But if you cannot, the tight very stenosis, like a hairline, then you balloon, but it's like 2 or 3 millimeter balloon, and then you do it. All right. So you go and deploy your stent. Okay. After you deploy your stent, you see like, 20% stenosis. I mean, we didn't balloon yet. We just deployed it, right? I see 20% stenosis. Do you balloon it or not?
Yes.
Or do you balloon every time? Not really. You see, in carotid stenting is different. You don't look for perfect result because this way you're looking for trouble, 20 to 30% is acceptable. So if you see stenosis mild to moderate, I will leave it alone, And second thing, when balloon, don't balloon with more than 4 balloon. Because remember, you have to leave a space for the clot to stay there. If you squeeze it too much, then the clot or the debris is going to go up into the brain. So it's okay to leave some stenosis because you want to leave a space for, especially if you have very tight stenosis, for the debris to stay there. And the second thing in the brain is just the main idea is just to track the debris more than open lumen very wide, So if I do it and I see only 20%, I'll leave it alone. If I see like 50%, maybe I'll balloon it. But again, you don't balloon to the side like we do in the lower extremity. If you put like 6 stent, we don't balloon with 6 or 5. Just like 4 is enough. Just want to be sure that lumen is wisely open and leave it alone. And when the balloon, you ask the anesthesia to be prepared. It's the time where you get bradycardia or asystolic, okay? And you balloon very quick, only a couple of seconds. You don't leave it like for a minute, what like we do in lower extremity. Just like in and out, like 2 seconds. Inflate, deflate, and that's it. After you finish, you see some waste is still there, leave it there. Don't worry about it. Don't be crazy about it, Okay, after that, you did that. Then you do compression angiogram. And let's say in a compression angiogram, you saw no flow in the stent. We saw about you take it out, you do angiogram, correct. But let's say you found like emboli to the MCA or RCA, what you do? Or patient suddenly he become like unconscious or become like cannot talk, what you do?
I will call neuro intervention for intracranial thrombectomy.
That's correct. So mechanical thrombectomy. Don't do it by yourself, okay? Get the neuro intervention to be there. So always it's better when you try guys to do stenting to be sure that you have somebody in the hospital all around, because these things has to be really,
المحاضرة كانت الساعة 7:30.
Sorry. All right. So anything about that? I think that's, and then you take it out and then you do compression angiogram. All right. When you do compression angiogram in the brain, you have to wait for the venous phase, So you cannot do like the legs, like you should do an angiogram. You have to wait until see all the sinuses vein filled up. So wait to the end. Don't do it like one shot and you stop. Because you have to see all the collaterals, all the way to the venous stage. Because the brain, small branch sometimes make a huge difference. So it's not like the legs. You just see flow and stop. You have to see all the branches all the way until you see the venous phase. To be sure that no small emboli went to the brain. All right, let's go to next. What if you need more pushes than the stop short technique, allow for reduction of the sheaths? I'll talk about TCAR. Dissection for stroke. What's the most reason for stroke after TCAR? I think dissection, right? Because no embolization. Because in TCAR, you have a reverse flow, you know?
Yes.
Well, let me ask you a question. This is about TCAR, but again, you're not doing TCAR, but maybe future you're doing TCAR. What happens if you're doing reverse flow and patients start having symptoms? Because you cannot shunt, right? And you do reverse flow. So sometimes reverse flow could be like you're clamping. When you do reverse flow, like clamping the internal, and many times you clamp the internal, you get like patient get symptoms because it's not enough collaterals. The same in TCAR, if you do reverse flow, and patient has not collateral, he may get symptoms or get a stroke. So what do you do?
Oh, I will stop my reversal and I will put a filter.
No. You see, because the problem is not the filter. You have a reverse flow. Huh? You mean you do it in different way?
No, I will stop the reversal and I will put filter and I will continue.
I never thought about it. I don't know if you can do that. Then you stop the TCAR and you put a filter. Okay. Because usually I stop the TCAR and stop the procedure, but it's a good idea. You just put the filter, so it keeps the inflow, and then you do a stent. Okay, good answer. What's the most common technique complications? What is it? Dissection, all the things. I think that's all. Access site dissection is stented. We talk access site dissection. Yeah, because what's common, like if you have a dissection in the area where you put the common carotid stent, you know, so how you handle it.
I will put a clamp in the proximal common carotid and another clamp in the distal common carotid just before the bifurcation. And I will do longitudinal arteriotomy and I will do packing of the dissection and patch closure.
Yeah, can do that. Okay. Well, just go transfemoral and put a stent.
Yes.
Can you do that?
You can do, but you need to make sure that you are in the true lumen.
Okay. I mean, the reason is usually done because doing TCAR, because mostly has a problem with that transfemoral because you have difficult arch or calcification, right? That's why doing TCAR. So I think going from below is not a good option. So what you did is the best way. Just open, tag it, and maybe patch it is the best way. All right, let's go to the next case. Any question first about this case before we go further? Any question?
Yes, Dr. Samir.
Yes, please.
In which step we can change the wire to stiff wire? In which step?
Okay, that's a good question. You talk about transfemoral, not TCAR, right?
Yes, the transfemoral.
Because TCAR is easy. Just go small wire. You just want to go through the common. You don't have to go to internal external because you don't need much support because you are there. So in TCAR, you just advance the wire about a couple centimeters in the common, and then you introduce your sheet. Okay. If the common is very short, you don't have like 2-3 centimeters to get your wire in because it's short. Then you do it like transfemoral. You do an angiogram, see where's the external. Then you direct your wire to the external. Then you introduce your sheath. Then you take it out. Then you do reverse flow. This is for TCAR. If you go transfemoral, always you have to put a stiff wire in the external because you can't put in the internal. So, but you cannot cannulate external with a stiff wire. So first you start with a whatever catheter, vertebra, headhunter, whatever catheter to cannulate the common. You do an angiogram, you see the external and internal, then you direct your glide wire to the external carotid, and you go inside. Then you push your catheters all the way inside the external carotid artery. After that, your catheter inside the carotid, external carotid, then you take the soft wire and you put a stiff wire. Then you take your catheter out, and then you put the long sheath. You place the long sheath in the proximal common carotid artery. Okay, then you take the stiff wire completely out. Then you introduce your soft wire 014, either spider wire or emboss shield to the external, to the internal. So first wire go to the external, and then you put the sheath. After you put sheath in the common, then you put your 014 wire in the internal. Is this clear? Is this your question?
Yes, yes, تسلم جدا.
Okay, no problems. Any other question about stenting? All right. I just had one case which I'm not able to advance really the stent, so I have to convert to open. I think it's the only case was very, very tight stenosis. And the problem, I cannot even put a filter. So when you cannot put a filter, I cannot even get the filter through the stenosis. So if you can put a filter, you cannot balloon it, because if you balloon without a filter, it's very risky. So if you cannot pass the filter through the stenosis, then the best way is to either do reverse flow, TCAR, or you do open repair. But don't balloon without filter. So when I say you balloon it, but at least you have the filter there first. So the stenosis has to be able at least to pass the filter. All right. Any volunteer?
Yes, Dr.
For next case? Yeah, go ahead, please. What's your name? Sorry.
Osama.
Osama. Yeah, Osama. Sorry. Yeah, Osama, go ahead.
74-year-old man who had a right carotid endarterectomy for asymptomatic carotid disease. 10 years prior presents to the clinic with the two separate occasions of transient right-sided monoocular blindness over the last week. He has no cardiac disease and otherwise is very active. He's post endarterectomy for asymptomatic and he has recurrent symptoms on the right side, same side.
Okay. So asymptomatic.
So I will obtain detailed history and physical examination of the patient.
So the same. Yeah.
Yes. I will order for him an ultrasound, duplex, and CT angio to check for for carotid stenosis and also for the any tandem lesion in the brain, as he has a recurrence.
Right, but the most important, always, guys, when it comes to ophthalmology, it could be not carotid. So always don't forget to check the eye, because could be had a glaucoma, something else. So while at vascular, always we think about carotid and TIAs and fugues, but always you have to rule out other things, you know. So when patient comes with with fugues, yes, I do carotid ultrasound, but also I think to ophthalmology, be sure I'm not missing anything else, you know. The same like patient comes with aortic surgery, previous aortic biofilm, and aborgia bleeding. Don't jump to aortic fistula. Yes, I mean, it's 1 hour in the diagnosis, but always get the GI to rule out more simple problems first. All right, so you said the ophthalmology, he said no ocular lesion. And what's that thing here? And he wants to know why he's having these symptoms.
I will
so he has a record.
Yes, I will work out this patient with ultrasound, CT, and I will do echo for him for evaluation of any source of cardioembolic. After the imaging, I will see. On the carotid duplex, his right internal carotid artery has big systolic velocity 400. And the velocity 160, has severe stenosis, more than 70%. The left internal carotid artery has no significant stenosis. What would you like to do? This patient, he has recurrent symptomatic right internal carotid artery stenosis, and as long he did the procedure before, so I will go for either option of TCAR or transfemoral. I will prefer transfemoral if it's anatomically visible.
Okay. Then it says sounds right. Significant anterior calcified plaque of the common carotid artery throughout its course and type 1 aortic arch. What surgery would you offer this patient? First, as type 1, but the problem, look what he said. Significant anterior, what he said, right? Why he said about this one, anterior calcified plaque of the common carotid artery.
This is one of the contraindication for TCAR in cases of unhealthy carotid or common carotid artery. But the type 1 aortic arch, it is doable. It is a contraindication type 3. So
it's good for, usually if you have recurrent carotid stenosis, we talked about that like before. If you have recurrent carotid stenosis, really the first option is stenting, not redo surgery, correct?
Yes, agree.
Okay.
To risk
and either TCAR,
yes.
For nerve damage, correct?
For nerve damage and
yeah, this is a problem. If you do redo, it's always increasing nerve damage. So better to do it for redo, always better to do, you know. Let's review what we did talk last week. We said about redo if you have carotid stenosis. So if we have carotid stenosis and after carotid, this first carotid surgery, it's the carotid surgery, okay?
Mm.
And you get patient with symptoms, and stenosis is about 70 to 99%. Then what's the treatment? What's the best treatment?
99%?
Yeah, like 70 to 90. And he has the symptoms.
We'll,
And he has
we'll do the surgery.
do surgery or
Yes.
stent,
Stent, yes.
right? I prefer stent as my first options because again, you don't want to do redo surgery on patient who's increase your nerve damage. Okay. So patient with recurrent, I'm talking about recurrent carotid stenosis after carotid surgery, and he's symptomatic, then the best option is stent first, or for some reason you cannot have a stent because arch, whatever, then surgery. Okay.
Okay.
So let's take the same scenario. Patient has a carotid endarterectomy, and he came with, again, 70 to 90% stenosis, but he's asymptomatic. So then the question, should you do him or not, and what you do?
An asymptomatic patient, redo
Yes.
70 to 90, I will not do him again.
You'll not do them. It's a controversial, you know. Some guidelines tell you to do them. Sometimes say not to do them. I think you can go both way, you know. It's a controversial issue, but some guidelines tell you go and redo them, you know. And again, you can do surgery or stent, but this is controversial, you know. If you tell me you don't do them, it's acceptable. If you tell me I do them, I will accept that, both of you. If he has restenosis less than 70, like 50%, and symptomatic, what you do?
Symptomatic and stenosis less than 50%?
Yeah, like
less than
40%.
Conservative.
Because medical management, correct. If asymptomatic less than 50, do nothing.
Yes.
Okay, so finish. Let's go to the stent now. He has a stent and he came back now with a stenosis. Again, stenosis 70 to 90% and he has symptoms. So what's the treatment for him?
Again,
I'll just give you all scenario. Yeah.
Yes, again, I will go for balloon angioplasty, then and restenting again.
Okay, or open repair.
Yes.
Okay.
If it is doable to do open, but the question here, why he did stent first? Why he didn't do the open in the first place? That make the question.
If it's good, it's good. But I mean, both options available. Put them both on the table. It depends how the anatomy, how far the stent can be removed or not, you know. But for me, if it's removable, I think better the surgery. If you can remove it and do it like a vein, because the stent, restenosis stent, if you just balloon it or put more stent, is different. Internal carotid is too small. So you put two stents inside each other's, it's not a very good idea. You know, and balloon alone will not work. So again, this is, you can go both ways. You see in the exam, I mean, nothing like black and white. So you can go, even in real life, you can go both ways. So this way, I think you can go with surgery or with a stent. If asymptomatic, 70 to 90 asymptomatic internal carotid stent, what do you do?
I will go for conservative.
This is conservative for sure, yeah. You see, in the surgery, we said yes or no, because you can do stent. Here, no. You don't want to do asymptomatic, you know, carotid stent to do surgery for him. And so this will leave him alone. Less than 50%, we leave him alone as medical management. Okay. So let's go next.
So he has a restenosis 90%.
Okay.
And he has one of the contraindications for TCAR and transfemoral carotid, as he has a common carotid artery, has a calcified plaque. So I will offer for him, if he's surgically optimum, cardiac-wise, I will offer for him redo, open.
Not stent? What do you think is the best?
As the stent, there is a high risk of a stroke regarding the calcified plaque of the common carotid artery.
No, not really. No. They put you this one just to get you out from TCAR. You see, they didn't put you. No, the stroke if you have problem was calcified in the arch. But they put this. They don't want you to do a TCAR because the best option this patient do a TCAR.
Yes.
But they won't take TCAR off, so they give you a type 1 arch, so you can transfemoral. So this one I will go transfemoral if you want the best stenting, you know.
Yes.
I think because redo again, it's not easy. A lot of dissection, redo neck, you know, nerve damage is higher. So what do you think is the best? I think it's the carotid stenting is the best transfemoral in this condition, you know.
Assuming in
in
case
this
of
condition,
type aortic arch, it is doable.
Yes, this kind of type of procedure we talked about before. The patient wake up neurologically intact, but later in the night in ICU, he developed a left hemiplegia. So he's in ICU, developed hemiplegia.
So I will do
what
first urgent CT brain to rule out hemorrhagic stroke.
Okay.
And I will reevaluate the patient regarding, I will do ultrasound. And also I will consult neurology for possible neuro intervention for possible thrombectomy of the thrombosis.
If it's occluded. Okay. Okay. I mean, in the exam, I think you have to be more like, provocable. Like, it may depend how's your institute. If it's CAT scan takes me like 1 or 2 hours, no. I mean, the first thing I want to be sure is stent is not thrombosed, So I may do the ultrasound is quick. If it's not, then yes, I agree with the CAT scan. And the CAT scan, you want to rule out any bleeding, because if there's no bleeding, first you give him heparin, right?
Yes.
And then if the stent is thrombosed, you think about mechanical thrombectomy. Okay. This can show thrombus within the stent. What do you do next? We talk about it. What if you cannot get the clot out percutaneously? What do you do?
I will do it open.
Open. So you open. When you open, how you do it?
And open, I will open transverse incision.
Okay.
That's in the same previous scar.
Okay. No, his head has a stent before. He doesn't have a surgery. He has a stent before. So he never had any neck. Neck is no surgery cut.
Okay, yes.
So you open normal cut?
Yes. Normal, yes.
Right. And then when you clamp, you clamp only the common and the external. Don't clamp the internal.
Yes.
Anytime you have a clot in the internal, don't clamp it because you want the back bleeding.
Back
correct?
bleeding to push the thrombus.
Right. Then I will open longitudinal, the common, because an extent is external, so I can take the stent out if I can, of course,
Then I will prepare my
and let the blood to come back, If you cannot, if they don't see blood, you can get a Fogarty, as we talked last time. You can get a Fogarty, but you should not pass it more than to the level of the mandible, okay?
Yes.
So you have to be very careful not to pass it too much in. And they do thrombectomy, and they do a commission angiogram as usual.
Yes.
Patient done well positively, but now presents 6 months later, emergency department with fever, neck erythema, leukocytosis, and strangling around the stent that terminated at the second cervical vertebra body.
Unfortunately, I will need to take this patient to OR and removing the stent, and I will cover the arteriotomy with vein patch.
Well, let's go step by step. So patient has an infected, right?
Yes, infected.
And you have a stent, it's going really high. Second cervical vertebra is really, it is a bit high. So what do you need to do before taking the OR?
Start antibiotics and resuscitation and.
Correct, but something else is important. Do an occlusion test, right? You have to do an occlusion investigation, right? Because you never know. You can go there, infection, edema. You don't know if it was ligation, bleeding. You have to just ligate it. So I'll take this patient. I'll do an occlusion test first. Be sure he tried the occlusion, just to give you an idea. Because then you have, if he can try the occlusion test, maybe it's the best way just ligate and take everything out.
Yes.
But if it's not, then you have to do a bypass. We don't do a patch. When you have an infection, you have to remove the whole stent. And you cannot just take it out and put a patch because the stent be inside the wall. So the whole thing's inflamed. So in this condition, you just got everything, the common, internal and external, the stent, everything. And you get a vein from the leg. And you do bypass from the common to internal. That's it. Forget about the external, okay?
Yes.
So this way you open, clamp proximal distal, common, take the external stent, internal, external, common, cut them all one piece to get them out. And get a vein and do bypass from the common to internal carotid artery. If the occlusion test is negative, I'll just ligate it. I'll forget about it. Okay? Because you don't want to put, like a bypass in the infection area. He may bleed again. Why take a chance?
Yes. And the
occlusion test in this patient, I think occlusion test in this case is very important.
Yes.
All right. in brief, how you perform procedure, we talk about it. And that's that. What constantly could you consider just removal of the infected stent with carotid ligation? We talk about it. If the occlusion test is negative.
Occlusion test, right.
All right, I think we're done with this one. Any question about this case?
Yes, Dr. Samer.
Yes, please.
Is it possible to ligate the external carotid and the distal external carotid part and transpose it to the distal internal carotid in case of infection?
Yeah, I get what you point. I don't think so, because you see the stent going is in real life. I mean, this is what some books they say that, but real life, you're going to, I mean, they have a hole in the common external and internal. So how are we going to do it? I mean, because you're going to cut because the infection stent in the common and internal and internal carotid artery. So how are you going to take it out first? And the second thing, when you take it out, how are you going to close this one? Still, you have a hole in the common carotid artery. You're going to put a patch. I don't think it's practical. I mean, you may see in some books they said that, but maybe for occlusion, not for infection. But I don't know. I don't think it's practical, in my opinion. The best way, just take everything out, just like it, or put saphenous vein interposition graft. It's the best way. Okay.
Okay, thank you. Okay.
Let me ask you a question. We are there. What's the difference when you do bypass in the neck than doing bypass in the legs? Using saphenous vein.
You don't
What things
reverse
you have
it.
to do different? You don't reverse it. It's good.
You don't
Important.
reverse
Don't
it.
reverse it. Okay.
In the legs, we
Yeah,
can
that's-
reverse saphenous.
Yeah,
And-
it's very important. Don't reverse it, because the neck valve has to be up, you know. Great. All right, let's go next so we don't waste time. Who want to take number 6? Why don't see female? Let's get some female here. Why don't female be part? Any female doctor want to be part? No. All right. I don't know. Ibrahim? Want to take it, Ibrahim? Maybe it's not there. Auda? Ahmed?
Okay, I could try.
Yes, please. Yeah, try. What's your name? Iman? Okay, Iman, go ahead. What year you are? Which fellow you are or graduate? What year you are?
First year fellowship.
Okay, great. Don't worry. Yeah, it'll be nice case to discuss. Don't worry. Go ahead.
75-year-old man presented with multiple events of left monocular blindness that he describes as a dark shade coming over his eye that resolved spontaneously over the past few days. He is an active smoker with a history of prior cabbage, liver disease, hypertension, and he had an MRI in the emergency department with no signs of an acute stroke. Physical examination is positive for a left carotid brevis and a normal neuromuscular.
Okay, so they'll ask you what you do first. So in the ER, they call you. You're first year. So what do you do in the ER?
I'd like to do a duplex.
Yeah, duplex ultrasound. Yeah, and complete physical exam,
And then-
correct?
CTA.
Okay.
The duplex should right.
I tell you, I'm the examiner. You answer. This is the examiner. I see that. The duplex showed that internal carotid is 50 to 69%. The right. The left internal carotid is occluded, and high-grade stenosis of the left external carotid artery with peak systolic velocity of 450 and end-diastolic of 120. How do you interpret this finding? So he has moderate stenosis on the right, completely occluded in the left internal, but severe stenosis of the left external carotid artery, okay? And he came with the left eye symptoms, okay? We know the left eye symptoms, that means we're talking about the left carotid.
Left carotid.
Correct?
But
Okay.
the left internal carotid totally occlusion for medical treatment.
Right. Correct. But he's getting symptoms, you know?
Yes.
And because it has a symptom and severe and external carotid stenosis. So because when you have an occlusion, either you have a stroke or no symptoms, correct? When you have an occluded artery, either you get a stroke or you don't get a stroke. You don't get TIAs with occlusion, correct? The occlusion happens when you have a TIA, small embolitis of the brain. When you have complete occlusion, based on either come with a stroke or we come with no symptoms, because if you have good collaterals, okay? But when you see symptom with occlusion, then we talk about what we call it. This is a very rare condition. We call it an carotid artery stump syndrome, correct? I know if you heard about it, you start first year, called a carotid stump syndrome, okay? So I'm going to ask one of the senior, maybe knows better, who can tell me about this carotid stump syndrome? How does it work? How we treat it? Why we get a stroke from carotid stump syndrome?
Occlusion of the internal carotid artery, and showering thrombus from the internal carotid artery to the external through the ophthalmic branch.
Okay, so very good. This is what we call stump syndrome. But let's think about it. If this is correct, so why we don't treat, if the left external carotid artery stenosis can give us a symptoms like a TIAs, so why don't we treat all left external carotid artery stenosis? This is a good question, right? If we're saying that this is because he has severe left external carotid stenosis and he has and the clot coming from the stump going through the left external through the branches to the ophthalmic, then you can tell me, okay, doctor, so why I should not, like every patient come with a left external carotid artery stenosis, I should treat him now because he may get, TIA through the left external carotid artery, but we don't do that.
I think because the chronic occlusion of the internal carotid artery will develop collaterals that would cause the issue.
This is correct, because if you don't have internal carotid is occluded, then you don't have, like I say, in the legs, you don't have good collateral. If it's collateral, but they are very small, this is the only thing. The second thing, even if you have collateral between internal and external, but the flow is not really, you don't have reverse flow from the external to the internal because the internal is open. So when the internal is open, everyone going its way. It's no reverse flow from the external to the internal. But when you have internal arteries occluded, then the ophthalmic artery will get reverse flow from the external. So now you get the flow from the external. Now anything goes through the external will go to the ophthalmic artery. The reason why most stump syndrome, they come with ophthalmic lesion. They come with a stroke because the main connection is with the ophthalmic artery. And usually from the facial artery or temporal artery, superficial temporal artery, with the smaller branches that was the ophthalmic artery. So this is the reason why. So the only in this condition we address the external carotid artery stenosis and the stump and then you have to have a stump. If you have a flush occlusion of the internal carotid artery, this will not work. So when you do the angiogram or CAT scan, you have to have a stump of the internal, which can create the clot and turbulence, and then this clot goes to the external to the ophthalmic artery. Is it clear or still not clear? Why we just, this is the only condition we address the left external carotid artery stenosis. Okay, I think hopefully it's clear.
Please, can you repeat again, sir?
Okay, I'll repeat that. What I'm saying is that when the internal carotid artery is open, the ophthalmic artery gets blood from the internal, does not get from the external, not get from collateral. Like if you have an SFA is open, the popliteal artery get the blood flow from the SFA, will not get from the collateral or from profunda. Even they have collateral, but it doesn't get. The main blood flow comes from the SFA. When the SFA is occluded, the popliteal artery get blood flow from the profunda. So any clot go through the profunda go to popliteal artery. But if the SFA is open, when you get clot in the profunda, the clot will not go to popliteal artery. It's going to stay in the profunda because the main artery is open. The collateral is not working. And the same here. When the internal artery is open, any disease in the external artery, they will not go to the internal branches. It will go all to the skin. So we don't worry about them. But when the internal artery is occluded, then anything goes to the external is going to go through the collateral because now you have collaterals because internal carotid artery is occluded. And the first branch from the internal carotid artery is the ophthalmic artery. So the first branch will go to the ophthalmic artery. So anything disease in the external carotid artery with internal carotid artery occlusion, all this clot from the turbulence from the stump or small emboli is going to go through the external, through the collaterals to the ophthalmic artery and cause the aneurysms fugax. So this is the reason why he gets the symptoms. This is the only condition. But if the internal is open, then they never get the symptoms. I hope it's clear.
Yes.
Okay. Let's go to the next. So what we talk about, custom, how we treat this patients. I think stuff for her first year. Any junior, a senior, but how you treat custom syndrome?
Yes, Dr. Samer. You do.
How you treat?
Yeah, you do external carotid endarterectomy and batch and you ligate.
Yeah, like the internal carotid artery, correct?
Yes.
Is any other solution?
You can do stenting from common to external. Cover
correct.
the stent.
What kind of cover or uncover stent?
Cover the stent.
Correct. This is the only time we use cover stent. So the other option to cover stent, and it's I think the best option from the external to the common carotid artery. All right. What nerve you have to watch out during external carotid artery dissection? Superior nerve, right? What the most nerve usually damaged during the carotid surgery? What the most common nerve? Hypoglossal. Okay, next. Third.
Considerances cervicalis, one of the three, or it's usually kind of ligatus cervicalis. Otherwise,
no, it's the nerve you see it a lot when you do carotid surgery. It's the third nerve.
Palopharyngeal.
No. It's very common, guys. You see it after surgery, but it's not an important. Yes, submandibular becomes a retractor. You see it a lot. Submandibular. So the most common is the vagus, hypoglossal, submandibular. But some people they have different, order. Some people they hypoglossal first and vagus. It's not important, but these are three more important nerves: hypoglossal, vagus, and submandibular. But when you do external carotid, most of it is the superior nerve. Okay, this is because it's very thin nerve and go next to the thyroid artery. So when you dissect around the external carotid artery, it's very common to cut this nerve because you can't see it. It's very, very thin nerve, So what happens if you get this supralaryngeal nerve? What could happen?
Loss of high pitch sound.
Yes, high pitch sound. Okay. All right. Let's go back to Iman. You still there?
Yes, sir.
Yeah, let's go number 8. Patient arrived in the PACU. So the patient arrived to the PACU and you are called frantically by the bedside nurse that patient is having a stroke. What will you do? So patient PACU and have a stroke. So what do you do?
CT brain?
We discussed that before. Yeah. I mean, if it's a PACU, I prefer to do duplex first to be sure he's not your surgery site being thrombosed. And then I will send him for a CAT scan to be sure there's no bleeding or this time. But if the duplex is negative, if it's positive, then take him back to surgery right away. If it's negative, then I stay for CAT scan to look for bleeding or emboli to the brain. Okay. There's no focal deficit, but you notice that lower lip drop that corrected with smiling. What do you think is going on? So he thinks he's a lip palsy. Yes, submandibular nerve injury. Yeah. You think this is a stroke? Do we call this stroke?
No. Full neurological examination to exclude the stroke.
Right.
I think
but submandibular nerve. Yes, go ahead.
I do full neurological examination to exclude other causes او ان هي تبقى stroke وخلاص يبقى هو ده غالبا mandibular nerve injury.
Right. So submental injury is not a stroke because some people in this medicine, they don't know. They say the lip palsy, they think it's a stroke. So you tell them, no, this is a peripheral nerve damage from the retractors. So you don't even get a CAT scan. Because I get many times a call from the medical people, oh, patient has a stroke because his lip has a lip palsy, So they want to get a CAT scan. I say, no, don't get a CAT scan. This is a lip palsy. It's because of the submandibular nerve damage from the retractor. So you don't need a CAT scan. It's not a sign of stroke. If the neurological exam is negative, of course, unless if you see something else. But if you just see a lip palsy, or drop, this is from nerve damage from retractor. What was cause we talk about it? Okay, you did a good job, Iman. Very good. You want to continue, guys, or you had enough?
Dr. Samer, I have a question.
Yes.
If you have
enough, just get the question. Yeah, go ahead.
If I have a patient who has an ulcerated plaque or fresh thrombus in the proximal internal carotid artery.
Say that again. Sorry. Say that again in the beginning. Is what? If you have?
Patient with fresh thrombus in the proximal internal carotid artery.
Okay.
And he is symptomatic. Can I use covered stent in this situation?
No, we don't use covered stent in the internal carotid artery at all. You know why is that? Because if you think about it, why use uncovered stent in the internal carotid artery? Because if you think about it, you should use covered. Because this way, you don't get any more debris, and less chance of embolize to the brain. So why we don't use routinely covered stent in the internal carotid artery? Unless you're dealing with aneurysm, but I'm saying in the atherosclerotic disease.
Area or
because, sorry? Because they found this high chance of thrombosis, I think because the internal carotid is small, 4 millimeters or 5, so you put a covered stent there, it's not a good idea. So nobody do that. So always use uncovered stent. Now they try to go with a mesh stent, which is multi-layer stent, because this way you can decrease. They can trap more debris in the wall. So now they're using a mesh stent or multi-layer stent, which is I think is a good idea in the future. But we don't use covered stent in the internal unless you have an aneurysm or pseudoaneurysm or infection with bleeding, something like that, or trauma. But in general, we don't like to use covered stent in the internal carotid artery. So to answer the question, no. If you have a thrombus, do mechanical thrombectomy. It's the best way. Don't play with the brain. Brain, we cannot play with like a leg. If you put a covered stent and then you squeeze the clot went up to the brain, you'll be in big trouble. Any other question?
We can have one case more.
Yes, please. One more. Okay, one more case. Okay, let's do this one.
One question.
Yes, please. Go ahead. You want to do it? Go ahead.
What about a patient with fibromuscular dysplasia?
FMD. Yes. Was the treatment?
Yes.
Yeah, this is the only one they treat they well with dilatation. So this one just dilatation, no stenting, no surgery, or just dilatation. They respond very well to balloon angioplasty. But very rare to see really if he has to be symptomatic, because if asymptomatic, leave him alone. We don't touch it. But if symptomatic, then you do just ballooning angioplasty. The same for the web. If you see a web and asymptomatic, leave him alone. If you see a web with symptoms, I think I prefer surgery because usually they're young people. You don't want to put stent. It's very simple surgery. You just go there, take the web off, and close it. You don't even have to put a patch. So I prefer surgery in case of the web. But still, you can do a stent. But I don't like it if patient's young. Any other question? All right. I think you have enough today. I don't see many volunteer today, so we can stop. Anything before we go? Okay.
Please.
Thank you very much. Yeah. Yes, please.
What about ulcerative plaque and insignificant percentage of stenosis?
I did not hear it very well. Say that again.
Ulcerative plaque with insignificant percentage of stenosis.
Where is that plaque? Where is that ulcer? Ulcerated plaque. Where in the common, internal, external, arch?
At bifurcation.
At bifurcation. Yeah, yes. I think this is if patient symptomatic or asymptomatic. You know, if it's asymptomatic, I will leave it alone, just anticoagulant. I mean, antiplatelets. If he's symptomatic, then you have to fix it. It depends, you know. If it's even ulcerated plaque, if it's not causing significant stenosis, I think antiplatelets would be enough. But if it's causing significant stenosis or ulcerated plaque, if you see big ulcer in the plaque, then I may go with a stent or surgery if it's symptomatic. So if I see ulcer, I'm saying you have to study your CAT scan and you see how your velocity and the symptoms. You have to look at all the things. Again, asymptomatic, leave it alone. If symptomatics, it depends how stenosis is a plaque. If it's not causing any stenosis, I will medically. If it's causing significant stenosis, I will treat it as, you know, as a sclerotic disease. I'll do surgery or stent. If there's any ulcers, then I'll be more prone to do like 50% with ulcer. I will do surgery or stent. Any other question? All right, guys. Thank you very much. Yeah, go ahead.
Yeah, معليش يا دكتور سامر. Last question.
Yes, please.
A patient who had axillobifemoral bypass. Is it possible to cause like Steele syndrome?
Yes, of course. If you have a proximal stenosis, yes. If you have subclavian stenosis, then you can get a Steele syndrome. Yes. Even you can get some people get MI from subclavian stenosis. They have like limma to the LAD, and you have subclavian stenosis, and most of it can cause an MI. Chest pain. So yes, you can get. So then you have to fix it with a stent. In common subclavian artery stenosis or occlusion, we treat it only if symptomatic. So if you see 90% stenosis or occlusion in the common and subclavian artery without any symptom, leave him alone. Don't touch it. Okay? Because sometimes they call you, they do a CAT scan and they found subclavian artery occlusion. And patient has no symptoms. They leave him alone. The only time we treat subclavian artery occlusion or stenosis if you have a symptoms. The same for vertebral artery. Only we treat it for stenosis or for symptom. The same for common carotid artery, only symptomatics. So the only thing asymptomatic is the internal carotid artery. We treat asymptomatic is the internal carotid artery. Anything outside of that, external, common, arch, subclavian, if there's no symptom, leave them alone. This is medical management.
I have one question.
Yes, please.
How we can deal with a young patient, 30 years old, presented with acute thrombus in the internal, fresh thrombus in the internal carotid, without clear source of thrombus? Is it and the patient presented with the feature of minor stroke? Can we deal with the anticoagulation alone, or what? Yeah.
No, if it's within an hour, now of course. I mean, now they do a perfusion for CAT scan. You know, they do a perfusion CT. So perfusion CT shows this brain of the part of this brain which had a stroke still viable. They can do a mechanical thrombectomy. This is the most common now, mechanical thrombectomy. Okay. And now we used to do it only to 4-6 hours. Now we can do it up to 24 hours. But many times they come and you don't know exactly when happened stroke. You know, maybe like patient sleep and wake up and he has has hemiplegic when he wake up. They bring him to the ER and you don't know when stroke happened because he was sleeping. You know, or the family came to the house and found their dad on the floor with a stroke. I didn't know when this happened. So now really the timing is crucial, but not very important. The most important now is to do a dynamic CAT scan or perfusion CAT scan. So now any patient, they come for stroke team, the first thing asks for perfusion CAT scan. And they look at this area. If it's still viable, has a perfusion, then they do. If it's too late, no perfusion, then they don't do it. So now they depend on perfusion CAT scan more than the timing, because timing could be not accurate.
Can a patient
But if you
start?
don't, but if you don't have a timing, if you don't have perfusion CAT scan in the area where you work, then go with hour. If you know exactly when the hours, I think up to 24 hours now, people they do mechanical thrombectomy.
If the patient exceeds 24 hours, can start anticoagulation just and follow up the patient if recurrent symptoms can do any intervention?
Yes, yes. I mean, if he came after 24 hours, that's it. I mean, again, I mean, I'm talking that in general, but we do a perfusion CAT scan. But if it's more than 24 hours, then just medical management. Yeah, like if they refer to you, like patient had acute stroke and refer to you from different hospital, they arrive to you like next day, then it's too late. You can't do anything. Just medical management. You know. Because if you open them, because you can get you can convert it to the hemorrhagic stroke, will become worse. Is the reason why we don't do it. Because if you do it on the dead tissue and you perfuse the brain, you get bleeding. You know, the reason why it's very important. Then situation can become worse. Then you really damage the patient more than help him. So you don't do it. No.
Can we do thrombolytic? Can we do thrombolytic therapy FTT brain free of hemorrhage in this case, in this situation?
Yes, but people they give like TBA peripheral. If you want to give TBA just like in the ER, just through the vein, you can do it, but you have to be sure at least an echo and be sure there's no thrombus in the heart or in the arch. Because if you have thrombus in the heart and you give a TBA, you break it and it goes more embolization. So don't give TBA in the emergency room unless you have an echo and be sure clot is free, heart free of clot. To do it through the catheters, yes, you can give TBA through the catheter, through the internal carotid artery, through catheters. But most people now prefer to do mechanical thrombectomy because they're afraid of bleeding. Especially tissue is already damaged now and they already have a stroke. So you give a TBA, they're always afraid of bleeding. So all day we used to give TBA, but now after.
I'm sorry for interruption. I mean catheter directed thrombolytic therapy.
Yes.
Not systemic thrombolytic.
Yeah.
Can we do it?
Catheter, yes, you can do it. But again, I mean, most people now they get away from it because of the risk of bleeding. So now they do mechanical thrombectomy. But yes, you can do it. Like lower extremity clot, we don't do now thrombolysis. It's very rare. Now most of we can do mechanical thrombectomy because all the problem with the TBA and bleeding and all the things. So yes, if you don't have mechanical thrombectomy, yes, TBA will work. But if you have both, then my first choice would be. Sorry.
The time window. Two weeks or 1 month for using
no.
thrombolytic therapy.
No, we're talking about the brain or legs.
The brain.
No, brain only have 4-6 hours. That's all. We're not talking about a weeks. Maximum is 1 day. That's it. If it's come after 1 day, that's it. Medical management. We don't do that because again, after 24 hours, the brain is already like dead. So if you reperfuse the brain, you get bleeding. So we don't do that. Again, the old teaching 4 to 6 hours, but now some people they extend to 24 hours if the brain is still viable. So, but any more than 24 hours for sure, don't touch it. So any patient come to you with a thrombus in the common carotid, internal carotid artery, in the brain after 24 hours, medical management, don't touch it. Can make it worse.
Okay, I see. Thank you.
No, yeah, TBA, thrombolysis, everything the same. But more than 24 hours, don't do it.
Thank you, Dr. Samer.
Okay. All right, guys. Thank you very much. Next week, I think I have a meeting and I'll not be there. Maybe the week after we can meet. We'll keep in touch through the WhatsApp. Thank you very much.
شكرا جدا دكتور سامر.
Thank you.
Thank you, Prof.
Thanks, guys.